To Maurita Murphy.
Hi there.
Hi, Maurita.
Hiya. Yeah, I've written down lots of things and opened up lots of links. I'm very excited to be here. Thank you for having me. I'm going to try and share my PowerPoint from this end. So just bear with me. I'm on my NHS laptop here and it wasn't behaving very well today. There we go, let's try that. Oh, are you trying to attach the... Aha,
Something's happening.
It worked. Can everybody see that?
Lovely. Yeah, we can see
Brilliant.
that, Maurita.
Do I win the prize for the longest title today? So, yep, shall I go for it?
Absolutely, when you're ready.
Thank you, thank you. So, hi everybody. Yeah, I'm going to be talking from kind of clinical observations today, really. And my title today is, what adjustments do you need to help you in therapy? But how this well-meaning question overlooks, in my view, the underlying problems feeding into ineffective therapy for neurodivergent adults. So a little bit about me, I'll introduce myself and where I'm kind of positioned from my observations, briefly talk about current therapy inadequacies, and kind of the checklists that have been created, in many ways a great step forward, and my clinical observations and kind of what can be done. I'm very open to discussion and views and comments here. So I'm a NHS psychotherapist and supervisor. I've worked in mental health for 30 something years. I also train trainee therapists and deliver training for anybody who wants to know anything about working with neurodivergent either students or clients. I made the I used to work at the University of Exeter as a trainer and supervisor, and I made them have me deliver some training, which I've done for the last 3 years now. So I'm part of the curriculum, which is great, only because I know them up there as well. I'm currently a doctoral student as well at Exeter, and I have been for quite a few years, self-funded there. Primarily my clinical work is where I'm coming from, but I have just dropped a day because I want to immerse myself now. I've been battling the hurdles of NHS ethics process, which nearly killed me, but I'm almost there. So wish me good luck over the coming weeks for that. So I'm ready to launch, and really excited to hear Katie there talking about epistemic injustice. It's a term I came across last year, and that's going to be really exciting. So I'm autistic and ADHD, and yeah, so anything that I refer to, please tell me if I'm misquoting or I've got research wrong, because maybe you'll know better than me. So I'm very open. So I'll just talk a little bit about therapy inadequacies, and from my position of working in primary care, NHS talking therapy service, so working with 16 plus, these are the kind of cohort I'm working with, and this is largely the research that I relate to and talk about. So we know that outcomes aren't as good for autistic people than for non-autistic people. And there's frequent reports of dissatisfaction with previous CBT. I hear it all the time from clients in our service, and of course then it gives CBT a bad rep because its CBT is rubbish. Well, actually no, maybe it's not being delivered appropriately and individualistically, which is what I often bang on about in my service, and I'll tell you what I've created to try and address that. And this study particularly talking about preferences of guided self-help rather than the typical therapy format. So we're really in the early days of trying to navigate our way through finding the most appropriate way of working with neurodivergent clients. And at the same time as well, clinicians lacking in confidence. There's no real standardized training unless you're like me and you make the training courses deliver it. So it's very spotty across the country, and I'm always interested to hear if anyone works in similar services, you know, what your provision is of training. But I know at the moment there's nothing standardized. There's rumblings of something perhaps to be more standardized in the future, like we have a long-term conditions pathway in talking therapies. It would be brilliant to have a neurodivergent pathway, which means all trainees get standardized training, which would be good. So, of course, more research is needed in these areas. And of course, we know with the Equality Act, there's been some movements to increase awareness about, okay, reasonable adjustments, what are reasonable adjustments? But there's still a big gap, which is what I've been observing, this ability to be self-advocates on the basis of, the fact that there's been lack of support, a lack of awareness and knowledge for autistic people, which I'll talk more about. Oh, someone's talking there. Thanks for muting. And we know that therapies given to autistic people without making adjustments and without taking autism into consideration are ineffective at best and harmful at worst. So we've got to be really careful here in what we're delivering and what we're training our therapists to deliver. On the back of raising awareness and reasonable adjustments, there's been several I call them checklists, which I don't mean to be disparaging in using that word, because they can be from the outset really useful to have a look at what we can think about in the therapy, throughout therapy, from before, during and after. So we've got the National Autistic Society, we've got NICE guidance suggesting things we can consider, the British Psychological Society, Royal College of Psychiatrists, and the NHS Talking Therapies Guide has released last couple of years quite a nice comprehensive guide. And this 156-page guide from the Authentic Research Collective, which has been devised from mainly autistic researchers and clinicians, which I think is the most comprehensive because it also includes the things that I'll talk about as being the gaps in knowledge here. So most of these kind of checklists, they echo similar common sense kind of practical recommendations, things about information, the environment, structure of sessions, communicate, how we're communicating, what we're communicating, and the therapeutic relationship, which is great. And we'll see, I won't read out all these, but an example from a section of the talking therapies reasonable adjustment suggestions here. And you see the very first at the top there is start by asking your patient if they need any adjustments, which is my whole point of my talk today, really, is that sometimes people don't know various reasons, which we'll talk about. So we've also got, again, I won't go through all of these, the links are there to explore more. So you'll see National Autistic Society talk about structure, having a positive approach, empathy, a low arousal, and linking in with others to their partners or loved ones or friends to support. And we've got SPACE framework for autistic adults created by a group of autistic doctors, which sets out 8 types of adjustments that they deem as being useful. So again, we've got sensory needs, predictability, acceptance, embracing neurodivergent ways of being, communication, empathy, the physical, personal space and boundaries, processing time, and having that emotional space. But my observations are these checklists enough? They're a great start, I think, in my opinion, but are they actually enough? So we know that some studies, particularly this one talking about autistic lived experience, outline challenges for service users, including anxiety about the therapeutic relationship, being understood, recognizing emotions, and pacing of sessions. And these are just some of the topics that are really important that may not quite be addressed in a typical kind of a checklist format. So we need more understanding. There needs to be more understanding to avoid clients feeling they need to keep masking. And there's complexities here, of course, when people don't even know they've been masking for a long time. I certainly see, particularly later identifying neurodivergent people who are realizing that they have been masking. So there's lots of unlearning to do, which is why the question is difficult to answer. What do you need? It's like, well, I don't know what I need because I've been masking for 30 years, potentially. And again, acceptance, understanding, most critical for successful clinical encounters. Having a clinician who understands autism is most important adjustment. Some autistic people report being unable to complete a course of psychological therapy or missing healthcare appointments due to a lack of adjustments. So you can perhaps see how we've got quite a way to go to be able to facilitate people being able to answer this question. So my observations, it sets up expectations, and there's also a lack of training here. So there are expectations that this comprehensive checklist will suit everyone, and I've seen this as a supervisor, and I deliver training within my service as well. And of course, as therapists, we all want to know, well, what do I need to do? And of course, I always laugh warmly at them and say, well, it's not quite that simple because each person's an individual. And I always quote it's actually from Silence of the Lambs, never assume because you make an ass out of you and me. That's one thing I deliver in all my trainings, is never assume that all autistic people are the same and that these adjustments, tick, 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 are what you need to provide. So talking with an individual is clearly what's most appropriate, because we know about diversity amongst neurodiversity. The other problem is lack of standardized comprehensive training on potential individual differences, or training coming from a deficit pathology, defining of autism rather than a neuroaffirming perspective, which of course perpetuates negative self-perspective. And as we've seen in Katie's talk as well, these diagnostic definitions, deficit language for a start, is how we're being described here. So I've got a very busy slide coming up next. Organisations as well, just to finish off this one in terms of, I'm seeing a lot, it's interesting that although organisations may have more awareness and ask these questions, what adjustments do you need? Okay, they're not always being provided. So yeah, we're at this interesting point in time where there's raising awareness, but still not a lot being done about it in terms of my observations of many, many people, myself included, within the NHS. That's another story. So assumptions and barriers to self-advocating. So there's an expectation that autistic people will know what they need. But I've seen this is often not the case. As I said, especially for late identifying adults, a lifetime of unconscious masking often leads to that sense, losing connection with, well, who am I? What do I need? What do I want? What do I even like? Because a lot of people have been masking for a lot of time. And of course, negative attitudes, whether it's society or family or school or workplaces, leading to internalized ableism and shame. So this busy slide coming up here is, again, my observations of these potential influences on the neurodivergent person's experience of therapy, because we know that, let's say, take the trauma, for example, higher numbers of autistic people who've experienced bullying, abuse, microaggressions, PTSD, the mental health problems across the board, depression, anxieties, and suicidality. There's the emotional interoceptive differences, there's sensory differences, nervous system regulation challenges. So even on just thinking about those things alone, there's a huge amount of differences in people's experiences there. And so if therapists are coming in and not really taking into consideration and having clear conversations about experience of emotions, alexithymia, what is your experience? Okay, then if that's difficult, we don't have to talk about what are you feeling about that. It might be facilitating that in different ways to get their experience. And so this is, when I deliver training to therapists, putting this information out as foundational awareness of differences and challenges that we might experience is absolutely key. And the sensory differences as well, which is perhaps taken more into consideration with some of the environmental concerns in the checklist, which is great. But the nervous system regulation challenges as well. Again, what I've observed is that some people often don't know about their own overwhelm, what that looks like, what causes it, what triggers it. It's often an all or nothing, which then people find very difficult to notice and regulate. And so sometimes what I've seen is that we need to kind of do potentially a lot of psychoeducation with clients about these types of things, unless they have their own awarenesses, which is fantastic, of course, but finding out more about these differences and challenges. And then we've got executive functioning challenges, which is, again, so key to explore and discuss in therapy. Because what we don't want, of course, is for people to, say, forget an appointment, and for that not to be taken flexibly. I've very much put across to our service about we need to be flexible here rather than our kind of non-attendance policy. And doing kind of home practice exercises, things that might help in between sessions. We've got to take those executive functioning challenges into consideration. And so again, these aren't part of any checklists. We're not getting training about it. So how are therapists supposed to know and supposed to kind of be aware about these things when, unless they've got their own personal potential interest? And also, the emerging research suggesting, what is the co-occurrence of autism and ADHD? There's a wide variety of research at the moment suggesting anything between 30 and 80% of that co-occurrence. And certainly my observations are that, the majority of people, and I'll talk about the courses that I run, majority of people identify as ADHD. So, unless we know that potential, again, as a therapist, how can we support and help people individually? We've got challenges with uncertainty, and we've got tendencies towards wanting to do it our best, which have other words like perfectionism, rejection sensitivity, demand avoidance. We've got hormonal fluctuations, menopausal stuff, masking, and of course there's an increased prevalence of certain physical conditions. So that picture is very busy, and it's my observations of, well, there's a lot to consider here in terms of why perhaps therapy isn't really, as good as it could be. So what can be done? Well, to help people answer the question of what do they need? Well, of course, epistemic injustice is one thing from the inside out, societal, but we need to remove barriers of shame and ableism. And there's a lot we can do in sessions to promote this in terms of listening to that individual, talking, discussing, communicating with an individual, and creating that therapeutic, open and curious therapeutic relationship. So we need to train clinicians appropriately as well. And we need to be coming from a neuroaffirmative perspective, even though the DSM is still in its deficit pathology mode. Training within my NHS service, putting that across, we have to be neuroaffirmative here. And studies like this one suggesting that positive autistic social identity has a protective effect on well-being. This neuroaffirmative attitude is crucial. Protective effect on self-esteem. And of course, if we address these kind of fundamentals, we could even be improving mental health even before we've started any therapy, typical therapy. So there's a lot that we could do. So if we're training clinicians, being aware of potential experiences and what that individual is going through, then we've got a better chance of being able to help them. So we can fill the knowledge gap. If therapists are more likely to be able to help clients recognise their challenges, then of course that will increase understanding for the client, and of course then assist in collaboration and potentially getting a lot more out of therapy. So for example, and I'll talk about the courses I run in a minute, but clients who again don't know about their overwhelm when they're struggling to process information, might be going into shutdown, and they're not consciously kind of labeling that or recognizing that as what's happening there. But if the therapist has been trained to be aware of the potential differences like this, they can spot that, they can help clients to talk about that, understand it better. And of course that will enable a conversation and a discussion about how to manage that. So rather than having these things as barriers to therapy, we can see them as essential segues to have these conversations, just as it would be with executive communication, executive functioning challenges. So, and of course we need to provide better support. So before, there's lots of kind of amazing support available for everybody in our service. I created and run, along with now 4 other therapists, 2 courses, again put in the context of NHS talking therapies, groups, courses in that sense, how we often operate in addition to the one-to-one. But my observations were that a lot of clients were coming in not having a great awareness of their own differences. And so this is why we started to do something about it. So by increasing clients' awareness of their individual differences and challenges, we can increase understanding, self-acceptance and compassion, all within that neuroaffirmative approach, which is often quite new to a lot of people. So the 2 courses that we run, it started off as 1 course almost 3 years ago now, and a year ago I split that into 2. So we have like a foundation course, psychoeducational based, 6 sessions, 1.5 hours. It is online because in Cornwall we're a very long peninsula, so practically that works and is often preferred as well. So that talks about nervous system challenges, sensory challenges, soothing, managing overwhelm, these coping strategies that's often very beneficial for people. The next course is 8 sessions of 2 hours, and that dives deeper into sense of self, self-worth, and working with a therapeutic approach to improve sense of self and compassion. And we've had some amazing quality feedback in the last few years. Descriptions about light bulb moments, life-changing. Out of 40 years of therapy, this has been the best. And somebody else, out of 30 years of therapy, this has been the best. And we see a lot. I do a little Mentimeter at the end of the courses, so people put down what they're going to take away, and compassion is still the biggest word, and that's been the same Mentimeter that I've put out across all these courses over the last few years, which is amazing to see. If people are going away, seeing people go away and advocating for themselves because they have that knowledge and awareness of their differences, and it's not, oh, I'm not defective, it's not me, leading people to go into their workplaces to say, well, actually, yeah, this is it, this is how it is for me, and be able to have a conversation and carry some pride about their differences, which is amazing. And even good quantitative outcomes amongst NHS standard kind of questionnaires that we have to administer. National targets for NHS talking therapies are to reach 50% of reliable recovery based on scores. Don't get me started on that in terms of questionnaires, and they're not really appropriate for neurodivergent people anyway, but that's a side issue. But we've reached 67% of recovery rates in one of the quarters last year, which is great. So the answer to, of course, what adjustments do you need is much more complicated, isn't it, than the checklist. It's a great starting point, but yeah, I'm interested to hear your views as well, because these are just my observations, and obviously I could do with a lot more research, which is part of my kind of doctoral research. Actually, is going to be in running online groups. So in the NHS, we run them as more structured information and exercises and participation. But what people come out with, as I've observed, is that sense of togetherness, communication, being with like-minded people, comments like, this is the first time I've ever felt in this space able to be myself. And I find it as a safer space as well, in terms of, with, I share as well appropriately. But creating that space, I've observed has been often quite amazing for people. So my research is going to be in an unstructured kind of group over quite a few weeks, and talking about asking people about their experiences of that, because I'm interested in, not that I'm comparing the two types of course, but I'll be reflecting in my writing on what I'm observing, differences. So yeah, that's me really. So any thoughts, comments, questions?
Lovely, thank you so much, Maurita. And yes, lots and lots of comments as our chat is working beautifully as always. So I know we started a tiny bit late, so I think we've got time for one question, and then maybe if you spend some time going through the comments yourself. There was a question about slides, and what I would suggest to people is, if you are interested in the slides, to contact the presenter directly. So if you are happy, Maurita, to put your contact details in, and then people can do that directly rather than sharing with the entire group. Yeah, and I've just learned a new term about being a chat lurker. I love being a chat lurker. I like that, Joe. I'm going to use it. Thank you, Katie, for doing the same. So any quick question just before we have a break, Damien?
Well, I was just going to comment about some of the links myself and others have posted in the chat, and in a study I was involved with, which was adapting a CBT intervention for anxiety. It was a co-constructed project type of thing. And what it came up with in terms of what adaptations needed to be made was basically neurodiversity affirming practice. And it's pretty similar to what you were saying. So it's like, without an understanding of things like sensory needs, what you judge a behavior or action to be from a clinician's point of view, if you don't have a good understanding and neurodiversity affirming understanding, then you can cause harm pretty quickly. And it's and I just think the more these adaptation projects are done, the more that's what they're going to find, in a sense. And it's but then it's, how do we turn therapeutic practice to be more neurodiversity affirming, which is a pretty big task, and one for all of us there, I think. But yeah,
I must say as well, I'm seeing our therapists who, even over the last few years of, since we've been delivering training in the service, I'm hearing a lot of really great things. I had just an informal discussion the other day, and I thought, wow, that's great, because they were, that's what they were doing. Yeah, this young lad who ADHD and very physically active, and they ended up throwing a ball to each other. That was therapy. She was at one end of the room, he was at the other, and I thought, yay, that's great. These, the therapists are there ready to soak it all up. So yeah, we've got great therapists, we just need to fill that gap a little bit.
What do we do about the not so great therapists?
Keep training them.
Well, some are beyond training. That's the problem.
True.
Well, so it's, perhaps we need a sort of our own kind of checklist or kite mark for approved therapists in the community or something. Or some way of sharing feedback and so on, because there are people who are actively a danger to us, it seems, as well. So it's just something off the top of my head, but how we can share that sort of knowledge in the community of where's safe therapy available and that sort of thing. Anyway, I guess if people do have questions, please pop them in the chat, because we're a bit late for a break now.